Should I start? Okay, so I'm Sacha Oomah. I'm one of the fourth-year residents here. I'm going to be talking about percutaneous drainage. I know in the objectives I said I was going to talk about biopsies as well, but there's just such an excess of literature on percutaneous drainage. I thought I'd focus on just that topic. My supervisor is Dr. Mark Vivian. So I thought I'd start with a case that I saw recently. This was a patient who's post-cardiac surgery and was referred to us for drainage of a periappendicular abscess. So you can see here there's a collection right adjacent to the ascending colon. And so we first got needle access into the collection, after which a guide wire was placed, and over the guide wire a drainage catheter was placed into the collection. So the patient came back 5 days later with feculent drainage from their drainage tube, and they wanted to know whether a fistula had developed. So we did a CT scan at that time, which showed a collection of air and stool in the right lower quadrant, in the region of where the drain tip is. You can see it both on the axial and sagittal images. And on the coronal images, it looks like the drain is still within that collection of stool and air. However, if you go a bit further back on the coronal images, it's a bit difficult to discern whether this abscess collection is separate from the cecum, because we have the ileocecal valve here, or whether it's communicating. So the next step was to do an abscessogram, which is basically where contrast is injected through the drainage tube and to see what it communicates with. And you can see here that the contrast is now communicating with the ascending colon. It was unclear in this case whether this represented kind of the abscess now communicated with the colon, or whether the tube itself was placed in the colon. So a few questions which arise from this case are, was drainage of this collection indicated? And if this counts as a complication, how can we avoid this in future cases? So that's kind of what I'm going to gear this talk towards. I think drainages are something that are being done in the community hospitals a bit more often. And so I think it's useful for radiologists to know how to best design the drainage procedures to be successful and to diminish risks. So I'm going to talk about before the procedure, how you can optimize the patient using the best approach, and also determining whether the drainage is in fact appropriate. So when you get a requisition asking for drainage, is it truly indicated? Then I'm going to go on to talk about the different techniques available, and if you have a tricky abscess, how to maybe get around those obstacles and drain it. And then after the procedure, assessing for complications and how to improve performance of abscess drainages in your department. So the American College of Radiology criteria are actually geared obviously towards an American system, so some aspects are not applicable to Canada. However, the themes are basically the same, and they break it down by scenario. So for the first scenario, they talk about an intra-abdominal abscess, in this case a periappendicular abscess, similar to the case I had opened with. And importantly, they always say that the patient is on antibiotics, so that is obviously the first line treatment of intra-abdominal abscesses. And they break it down by saying on the rating scale of 1, 2, and 3 indicates that it's usually not appropriate. 4, 5, and 6 may be appropriate based on the clinical scenario, and 7, 8, and 9 means that it is usually appropriate. So in the case of an intra-abdominal abscess, importantly here, it's 3 by 4 centimeters. They are saying that percutaneous drainage is usually indicated, and this is usually the best way of treating it. Percutaneous drainage followed by delayed appendectomy may be indicated in some cases. Needle aspiration is usually only indicated when you're trying to hone your antibiotic therapy, and if the patient is not improving on kind of broad-spectrum antibiotics, and they want to narrow that down. Conservative management in surgical drainage is usually not indicated. They also talk about the fact that if the collection is less than 3 centimeters, antibiotics alone are usually sufficient. So if you get that rec across your desk saying that they want you to drain a 2 centimeter collection, probably not needed at that time. Intra-abdominal abscesses can be from a number of causes, most commonly appendicitis, diverticulitis, Crohn's disease, or post-surgical. And contraindications to performing a drainage is if there's peritoneal signs, active hemorrhage, or lack of maturation of abscess wall. These are relative contraindications, but they're usually trying to prevent drainage in the case that there would be hemodynamic instability or worsening sepsis. There's not a lot of literature out there as to how much percutaneous drainage is helping. That said, before the advent of percutaneous drainage for diverticular abscess, the treatment was colectomy, and now percutaneous drainage obviates the need for colectomy in approximately 85% of cases, which is a significant benefit. And as well, percutaneous drainage reduces the complications associated with periappendicular abscess, and it reduces morbidity and mortality with Crohn's abscesses. That being said, the majority of patients with Crohn's abscess, roughly 50%, will require surgery down the line regardlessly. So the second case is talking about a patient who has intra-abdominal abscess that has a 12 French catheter placed in the collection. Drainage is minimal at 25 mils per day, and it's not changing on CT. So in this case, they're saying that it's usually appropriate to upsize the catheter. So this would basically be exchanging the 12 French for a larger, like a 14 French catheter, and this is supposed to improve drainage. The next therapy which can be indicated is intracavitary thrombolytic therapy and drainage. There's not a lot of evidence backing this, but in the States it seems to be quite commonly used. In Canada, I think the cost is somewhat prohibitive to its widespread usage. And then laparoscopic and surgical drainage may be indicated if you have an abscess that is causing the patient to be significantly septic and percutaneous drainage is not working. Obviously, antibiotics with or without drain removal in the case that it's not resolving is usually not indicated. So this is just specifying that complex collections are usually caused by either septations within the collection or fistulization to another system. You can also have fistulization to lymphatics or neoplastic tissue, which can make the collection more difficult to treat. And the idea behind using thrombolytic therapy is that the septations are actually made of fibrin strands, so the thrombolytic therapy will degrade those fibrin strands within the collection and precipitate drainage of those loculations. So compared to just using saline alone for irrigation of an abscess, thrombolytics increases the treatment rate from 22% to 72%. If you have an abscess that fistulizes with the GI tract or other systems within the abdomen, you can try using ablation of that tract with glue, and that's shown to be in a small series of 11 patients. It was shown to be 100% effective. So these are kind of more troubleshooting measures. Prolonged catheterization can also be effective for fistulized abscesses in clearing them, but it takes some time. For sterile collections such as cysts, lymphoceles, and seromas, where they have a defined cyst wall, you can use sclerotherapy with ethanol or tetradecyl sulfate. There's a couple of other agents you can use, and that actually will coapt the walls of the cyst together so that the fluid doesn't reaccumulate. So variant 3 talks about a patient who has a splenic abscess, again, greater than 3 centimeters, whether percutaneous drainage is appropriate or not. And they're saying that based on the literature, it usually is appropriate, and this is in fact considered second-line therapy after antibiotic treatment. This used to be treated with splenectomy up until the mid-1990s, so percutaneous drainage is just starting to be more widely recognized as a treatment modality for splenic abscesses. And again, needle aspiration is really only indicated if you're trying to hone down your antibiotic therapy. So kind of the take-home message is that if a collection's less than 3 centimeters, usually antibiotics alone are sufficient, plus minus needle aspiration if you want to target your antibiotics. But if it gets larger than that, you can try percutaneous drainage. Also interesting is that amoebic abscesses usually don't require percutaneous drainage. They tend to resolve with medical therapy alone, even if they're larger than 3 centimeters. Yeah, so case 4 talks about peripancreatic collection, and they've designed a number of criteria based on the Atlanta classification for pancreatic collection. So you can either have peripancreatic fluid collection that over the course of 4 weeks matures to become a pseudocyst. And so for pseudocysts, they say that percutaneous drainage is sometimes indicated, but actually it's preferential to use endoscopic cystgastrostomy if you have a gastroenterologist who's willing to do that in your center. You can also do surgical therapy, which is sometimes indicated. Conservative management is usually not indicated. And this is in the case that the collection is either infected or causing the patient's symptoms, obviously, symptoms such as obstruction. They also talk about, in the case of if you have a peripancreatic abscess or infected pancreatic necrosis, sometimes necrosectomy, percutaneous necrosectomy is indicated in the States at least. So that would be percutaneous placement of a catheter into the infected collection, trying to drain it. And sometimes they can put 2 catheters in that infected pancreatic tissue and basically try and irrigate through one catheter and drain through the other to remove that necrotic tissue. The next scenario is a patient with thoracic abscess. So in this case, percutaneous drainage is usually indicated. Surgery is usually not indicated unless percutaneous drainage fails. So percutaneous drainage of mediastinal abscesses has usually been shown to be 100% effective for mediastinal abscesses, and this obviates the need for surgery, and 83% effective for lung abscesses refractory to antibiotic therapy. If you have a patient with a bronchopleural fistula, they'll require prolonged drainage, and you want your catheter to be put to water seal suction, and basically that prevents air from backtracking into the pleural space. And also, if you're doing a chest drainage, you can use pleurodesis for malignant or persistent large pleural effusions. And the last clinical scenario here is a patient with a pelvic abscess, in this case a tubo-ovarian abscess. And there's a number of different modalities you can use here. So percutaneous drainage is usually indicated if you have a tubo-ovarian abscess that's not resolving. And you can use the transvaginal approach. Transvaginal tends to be preferred in certain cases, and I'll go into that more in a bit. Transgluteal is another approach that you can use. Needle aspiration, again, is kind of if you're trying to hone your antibiotic therapy. And in fact, conservative management is sometimes indicated because the majority of these tubo-ovarian abscesses will resolve with antibiotics alone. And kind of surgical drainage is usually not indicated. Interestingly here, you can also use the transrectal approach, and sometimes you can use endoscopic ultrasound if you're having difficulty either transvaginally or transrectally. But the problem is that this can often superinfect the collection, so they tend to shy away from this if possible. So for pelvic abscesses, they obviously advocate use of the most sterile route possible. So this would be either intra-abdominal or transgluteal. And transperineal route is usually indicated in patients who've had a previous low anterior resection. The anatomy tends to make it more amenable that way. So as I mentioned, 2/3 of tubo-ovarian abscesses resolve with antibiotics alone. However, for women of reproductive age, if they have a ruptured tubo-ovarian abscess, you can increase their fertility down the line by draining it percutaneously from 4 to 15% to 32 to 63%. So it still has its role. So that was kind of dry, but I'm going to go a bit more into how you can optimize your patient and then get into some more interesting stuff. So patient optimization, the indications for drainage, they say this is from the quality improvement guidelines from the ACR. So they say that you have to have a collection that you suspect is infected or that you need to characterize what type of fluid it is, and that the collection is producing symptoms. So either symptoms of sepsis or SIRS or obstruction, something like that. It's also indicated if there's this is a temporary maneuver to stabilize the patient's condition prior to definitive treatment. Relative contraindications is a significant coagulopathy that can't be corrected. Interestingly, there's no absolute contraindications to percutaneous drainage, so it's in our judgment. if you have an unstable patient, either hemodynamically or airway, if you don't have a safe pathway to get to the abscess, or if the patient is not able to lay still or cooperate with us for the procedure. And so in general, we like our platelets to be greater than 50,000 and our INR to be less than 1.2. In urgent cases, they say the INR can be less than 1.5. We tend to use, a 1.2, 1.3 in our institution. And also keep in mind that there's conditions that even if they have this blood work can affect the function of the platelets to clot. So uremia, liver disease, von Willebrand's disease, or paraneoplastic syndromes. Also drugs. So there's a big laundry list of drugs that can affect platelet function, and in fact, probably the majority of your patients will be on some of these medications. I'm on caffeine right now, so my platelets aren't working as well as they should. But not that these are contraindications, but just that you should keep in mind if you have a patient with lowish platelets and is on a majority of these medications, you should maybe be more suspicious of post-procedure bleeding. So they talk about in patients who are not already on antibiotics to give them broad-spectrum antibiotics 1 hour before the procedure. And they say that giving antibiotics 1 hour before procedure doesn't affect with culture and sensitivity, so it's still safe to do. And this is thought to diminish subsequent sepsis from either spillage of infected material or hematogenous distribution. So in terms of selecting the right approach, you can use CT or ultrasound. So ultrasound is real-time, which has a lot of benefits. Unfortunately, you can't see beyond bowel gas, so CT has the better spatial resolution and depth. However, with ultrasound, you can also angle, so you can get angled planes, and you don't have to work in just the axial plane. So you can sometimes get around structures that you can't with CT. There's also the way of using cross-sectional imaging to basically guide your ultrasound drainage. So the computer will link up, based on a pre-procedural cross-sectional scan, your images and help you discern kind of deeper structures. And sometimes if there's perhaps a collection that you'd only see on MRI and you can't see it on ultrasound, this will help you target where it is. So this is kind of what it looks like as you're sweeping through the abdomen. It'll give you a reconstruction image of the abdomen based on, in this case, an MRI. So in terms of different approaches, you can use transabdominal, and there you can sometimes, if indicated, pass through the liver or the stomach to get to where you want to go. You can also go transpleural, transgluteal, transrectal, and as I mentioned, some of those other ways. It's important to mention that, although this sounds obvious, you have to keep in mind the anatomy when you're going through these different methods. So if you're going transabdominally, you want to obviously watch out for the inferior and superior epigastric vessels. If you're going retroperitoneally, you want to avoid the vessels, obviously, but you also want to avoid the ureter. Sometimes if you're worried that you're near the ureter, you can use contrast administration and wait for the urographic phase, and that'll opacify your ureter so you can avoid it. You can also sometimes pass through the psoas, but it's important to remember that the genitofemoral nerve passes anterior to the psoas muscle, so the patients can experience quite significant groin pain if you hit that structure, so just try and avoid the anterior psoas if possible. A note on transgluteal drainage. So we have to pass through the sciatic foramen and the gluteus muscle to get to the pelvic structures. The gluteus muscle can be quite large in some patients, and so dilatation of this structure can cause them a significant amount of pain. And this actually is the major complication of transgluteal drainage is pain. So conscious sedation and adequate analgesia are usually indicated. Chronic pain has been associated with passing through the piriformis muscle. So if possible, it's better to go inferior to the piriformis. And you want to obviously avoid your nerve structures and your vascular structures. So the gluteal, inferior gluteal artery, as well as the sacral plexus and sciatic nerve run both anterior to the piriformis and then lateral to the sciatic foramen. So here we have a big collection in the retroperitoneum, and this is the level of the piriformis. So we have the piriformis muscle here. Here's the inferior gluteal artery and the sciatic nerve. So if we go further caudal in this patient, you're now passing through the sacrospinous ligament. The sciatic nerve is off to the side, and if you go just adjacent to the bony sacrum, you can pass into this collection with minimal trauma and hopefully not a lot of post-procedural pain. In terms of selecting the right catheter, from my research, it looks like most of the catheters are fairly comparable. I'm not certain about cost. I contacted a couple of the vendors, but they were not able to get back to me on cost of the catheters. But the majority of these catheters will have a hydrophilic coating. They'll have a radiopaque marker so you know where your pigtail is done. And they'll have basically kind of this material which you can pass alcohol through if you need to ablate the cyst at the end, or and it's rigid enough to keep the material flowing. And some of these will have different mechanisms for locking the pigtail in place. This graph, I didn't want to overwhelm you with this, just these are the ones that are highlighted, they're the most common ones. It just goes to show you that you can have a locking pigtail. If you want, you can have a J-tip, which doesn't lock. That's usually if the collection is too small to get a pig to curl in the collection. And you can get different lengths as well. So as I mentioned, you can get shorter catheters and longer catheters. And you can also get large bore catheters. So you can see here that the French size is quite a bit larger. Of note, if you're going to use a large catheter, they don't actually make them in the pig format. So you can only use a non-locking angled catheter once you get up to these larger sizes. And the French sizes here just kind of mention that the largest catheter you can get is close to 1 centimeter, whereas the ones we usually use are about 0.5 centimeter. And that's the internal diameter. So this just is another one. This is the Angio-Dynamics total abscession catheter, which we use here at HSC. And this just goes to show you it has the same features. There's a pigtail with side holes, radiopaque marker. The difference really is in the locking mechanism for the pigtail. So this will click into place when you've locked it. And this is the catheter that they use at St. B, which is the Cook's catheter. And this shows you that the catheters come with a stiff cannula, which can be either metal or kind of a more flexible plastic material. And the locking mechanism for this is basically you pull the string over a little tab to lock it in place. And this one is also hydrophilic and has that radiopaque band. So this is material published by Boston Scientific, so you have to keep it with a grain of salt. But this is trying to say what the difference in the physical characteristics of the drainage tubes are. So if you have something that's more flexible, it's going to be not as buckle resistant, and it may kink. So kinking is when you have the tube bends, and then when you unfold it, it keeps that bent shape even though it's unfolded, whereas buckling is actual collapse of the lumen of the catheter, and flexibility is as it sounds. So you can see here, I mean, the dark blue line is the Boston Scientific drain. So this is obviously, they're trying to show that it's better than the rest of its competitors. It's based on, they use 3 catheters in each case, so they have a small sample size. But basically, they're trying to say that there's not a huge variation in the physical characteristics of the drains. You can obviously, this is just to compare all of them, you can obviously choose one which is a bit more flexible if you're going through less muscle, because that can be more comfortable for patients. If you're going through something larger like the gluteus muscle, you want something a bit more rigid so that it doesn't collapse when they contract the glute. And that tends to be a little bit more uncomfortable for patients because it is more rigid. And so I did find out some cost information. So at the St. Boniface catheter here that we use, the Cook catheter, is $120. And the rest of the abscess drainage equipment, like the bag and everything like that, is $170. In terms of technique, there's basically 2 techniques. You can use either the trocar technique or the tandem trocar technique or Seldinger technique. So the trocar technique basically means that the drain is mounted on a sharp inner cannula, and you use that to puncture through the soft tissue and then place the catheter into the collection, and you basically push the drainage tube off of your inner cannula into the collection, and it will then curl in that collection. You can use the tandem technique, which is similar to the trocar technique. You just put a needle in first to confirm that you're in the collection, and then you put your catheter on the stiff trocar into the collection adjacent to your needle. And then there's Seldinger technique, which involves after you put needle placement, you put a guide wire through that needle, and then you remove the needle. Keeping the guide wire in place, you put serial dilators over the guide wire, and then you put your drain on that plastic flexible cannula into over the guide wire into the collection. So I don't want to beat this to death, but there's advantages and disadvantages to each technique. So the advantage to using Seldinger technique is that you have more control. The advantages of the tandem trocar technique is that it's faster, it's single step, and sometimes when dilatation of structures is painful, you can avoid that pain. And so the disadvantages of the tandem trocar is that sometimes the catheters that come with the tandem trocar kind of kit have fewer side holes, and often it's difficult to reposition this. So if you want to reposition using the tandem trocar, you basically have to take the tube out and put it back in, which is creating more trauma. So as I mentioned, Seldinger, you have more control, and you can sometimes drain larger collections and deeper collections. It's more time consuming, and you don't always see the entirety of the guide wire when you're draining the collection. So in terms of troubleshooting, let's say you have a collection in the retroperitoneum, as in this case, which is infected, and the patient's septic, but you don't have a good window. So in this case, there's bowel all around the outside, and you can't really go retroperitoneally because there's the kidneys and a bunch of vascular structures. So the first thing is to try positioning the patient differently. So you can have them, in this case, right side down, then left side down, then right side down. Then oblique. So in this case, obliquing the patient opened up a small window between the colon, and you can see here that they put their needle in and then subsequently obtained guide wire access to this retroperitoneal collection by getting them in maybe like a 20-degree oblique position. Another thing you can do is try hydrodissection. So in this case, there's a peripancreatic fluid collection, but we're obscured by colon and kidney. So what they do is they put a 20-gauge Chiba needle in first and inject sterile saline. And what this does is it basically moves the colon away from the kidney and creates a plane where you can subsequently put your needle into the collection through this sterile saline pocket without traumatizing any intra-abdominal organs, and pass the catheter into this collection that way. You can also angle the gantry. So like we do on head CTs, you can angle the gantry to kind of in the craniocaudate plane to get a different approach. So in this collection here, you can see that we're posteriorly limited by the bony pelvis and anterior by loops of bowel. So what they've done here is they've angled the gantry by 15 degrees, and this opens up a small window where we can go transgluteally and basically access this collection. And here on the post scan, you can see that they've successfully put the drain in that collection. And the last thing you can do if you have a tricky collection is you can traverse an organ you normally wouldn't. Keep in mind this is not without risks. So every time you pass through something like the liver or stomach, you're opening yourself up to more post-procedural complications. However, if the patient is significantly septic, this may be indicated. So in this case, they have a transhepatic collection, and they've passed the catheter into the perihepatic collection by going through the liver. And this is published an acceptable means of treatment, but you have to keep in mind that there are complications. The other way is, so in this case, there's a peripancreatic collection, and they go percutaneously and basically transgastrically into the collection. Now, for peripancreatic collections, this can be used to establish a percutaneous cystgastroscopy or cystgastroenteroscopy fistula, to basically allow the collection to drain into the stomach long term. So in this case, it is beneficial, but there can be complications associated with spillage of gastric material into the peritoneum, abscess formation. Even though the gastric acid makes the stomach a bit more of a sterile environment, you can have downstream peritonitis. So after your procedure, everything went well and you're all happy, but you want to assess for any complications. So you want to assess for proper placement of your tube, hemorrhage, and perforation by doing a few slices through where you've put your catheter. And you obviously want to monitor your patient's vital after the scan. The drain should also be secured to the skin. So either using a butterfly adhesive as we commonly use, or you can use a locking loop suture to basically keep the patient from pulling it out. Sometimes the patients will be confused. You can also use a locking pigtail catheter, as I had mentioned, and this prevents the patient from removing it. So here we tend to recommend irrigation of 10 cc's of sterile saline 3 times a day to ensure that the catheter was going to drain. In centers in the States, they use thrombolytics, as I had talked about earlier. So, for example, you can use 125,000 units of streptokinase twice a day. In the papers that I read, they recommend after you administer the thrombolytics, you basically clamp the tube and allow it to sit in the collection for 30 minutes and break down the septations, after which you irrigate it with 10 cc's of saline and put it to free drainage, and then that collection should start draining a bit more of the loculations. So this has been shown to be effective for multiloculated collections or infected hematomas. Sometimes you'll get a call from the ward saying that they want to remove the catheter and they don't really know how to do it. So first they should cut the locking string for locking pigtail catheters and try and remove it that way. If it's not coming out, they may need to cut the catheter itself, because the locking string will actually pass through the catheter itself. So they can cut it and try and pull. If that doesn't work, then you should tell them to clamp the end of the tube, and they may need to have one of us remove it by using over-the-wire technique, which basically means passing a guide wire into it to uncurl the pigtail and pulling it off. Often it's just easier to do a catheter exchange at this time. So in terms of post-procedural complications, the one you want to look out for is hemorrhage, obviously, in the immediate post-procedural time. So in this case, there's a collection where a catheter has been placed. In this one, they went transpiriformis. And so you can see here that there's a hematoma in the region of the piriformis, and you actually have extraperitoneal hemorrhage as well. So in this case, you obviously want to stabilize the patient as much as possible, and then call your friendly interventional colleagues who do a conventional angiogram and find that there's a pseudoaneurysm of the inferior gluteal artery, and then they would have to coil that at that time. You also want to keep in mind that there can be late post-procedural complications. So this patient was a liver transplant recipient who had a collection that was infected, and a percutaneous catheter was placed within it. They come back 2 weeks later with the collection having increased in size, and basically an abscessogram was performed at that time, which shows that there's communication from the abscess with the biliary tract. So as I had mentioned before, whenever you go transhepatically, you can basically cause a fistula between any of the structures that pass through the liver. So a biliary fistula, a portocaval fistula, arterioportal or arteriovenous fistula. So those are some of the complications associated with hepatic drainage. So if you have a collection that's not draining, you want to assess and ensure that all of your side holes are within the collection. This also prevents seeding of abscess material outside of the abscess and worsening the patient's sepsis. In some centers, particularly in the States, they recommend that radiologists follow up on patients on the ward, and this is to assess for adequate drainage and to patency. So if you're experiencing diminishing returns of abscess, then they recommend either upsizing the catheter, repositioning the catheter, which can be done over the wire, or administration of thrombolytics. It's also a good way to assess for complications of our procedures, such as wound infections. And if things go wrong, such as perforation or bleeding that you can't control, don't be afraid to consult surgery. So how can we then go about making our drainage procedures more successful in our departments? So the best way we can do this is to kind of have guidelines for ourselves. So the quality improvement guidelines from the Society of Interventional Radiology and ACR talk about 95% success rates as kind of our target for aspiration of fluid and fluid characterization, whereas successful drainage of a collection should be at 85%. Also, they recommend having guidelines for complication rates. So once you pass the suggested threshold here, then you should basically be sitting down with your department and saying, you know, how could we improve our procedure? Maybe there's something from this ground round talk that'll pop into your mind as to how you can improve it down the line. But basically, they talk about 1 to 2% rate of septic shock being acceptable in the literature, and up to a limit of 4% in our drainage procedures. Bacteremia requiring new intervention. Hemorrhage requiring transfusion, 1% reported rate, which is actually fairly uncommon. So if you have it occurring in more than 2% of your cases, you want to maybe reevaluate why this is happening. Same with superinfection, bowel transgression, and pleural transgression. So this pleural transgression, they're talking about abdominal interventions only. They don't actually specify this in the adult guidelines, but in the pediatric guidelines, they talk about pleural transgression requiring additional intervention for chest procedures. So this would be placement of a chest pigtail catheter after to drain your pneumothorax. So this is obviously going to occur more frequently in the rate of 2 to 10%, and they recommend a threshold of 20% before you start looking at what could be going wrong in your department. So in terms of minor and major complications are those which have either no consequence or nominal therapy with an overnight admission but no consequence, whereas a major complication requires therapy and a bit of a longer hospitalization, so either 48 hours or longer than 48 hours, and can occur in permanent sequelae or death. And so in smaller centers, let's say you end up working out at the periphery after this, and you don't always reach those thresholds with some of the other procedures because you're just not doing it commonly enough. So they recommend if you have an overall major complication rate of 10%, you should sit down with the techs and nurses and other radiologists in your department and say, how can we improve our procedure? And maybe some of the things I've talked about this past 40 minutes will help you out in achieving a better procedure and less of a complication rate. Thank you. Any questions? Anybody from St. Pete? Sure.
I think we still have some available, but in material with thicker pus-centered or infected hematomas, sometimes we use larger sump catheters.
Okay.
Have you? Because you said most catheters are the same. So there's actually some catheters, McGann has invented them, and they have a separate port with a filter on it. And I think some other companies make them that allow air in, and then it allows catheter. So the theory is that the catheter doesn't get plugged by the material coming out because there's a port for the filter to allow the air in.
Right.
I've actually put some, when it's an infected hematoma or very thick pus, I put some 12 or sometimes even 14 French catheters in for those with a sump. And I just wondered if you came across that.
Yeah, I came across it. Like Cook sells a sump catheter as well. I didn't come across it in any of the guidelines per se. I think they were just talking about percutaneous drainage as a whole for most of the guidelines, but that makes sense as treatment as well.
It sounds easier than using thrombolytics for thicker things. You just put in a larger sump catheter.
Sure.
And that's what I generally do for things that I think may not drain well. So it's just a comment and a question.
Sure.
If you came across that.
That's a good approach. Thanks. Any other questions? All right, well, thank you.